baby was a 12-year-old female spayed feline, and there she is. And I guess we have the right to say she could have had polydipsia here based on this picture. Okay, her history was that she was normal until recent illness. And then she had a sudden onset of weakness, depression, and anorexia for 2 days. The cat had been seen by a referring colleague in the area. Surprisingly, there was no history of polydipsia or polyuria. There was no vomiting reported as well. And remember that, because when we get into the chemistries, we're going to start asking more questions. So we have a sick cat that's weak, basically, and it hasn't eaten in 2 days. And certainly that's not pathognomonic of anything. On physical examination, the temperature was 99 degrees Fahrenheit, which was normal. Respiration's regular, and the heart rate was 160. Now, this was at the time of admission. The cat was quite mentally depressed, 10% dehydrated, and not surprisingly, there was minimal hepatomegaly, most likely due to some hepatic lipidosis secondary to the diabetes. Now, these are the lab tests that were sent over with the cat from the referring veterinarian. And you can see here I have the System International units for our Bulgarian colleague, if he's checked in or she is checked in. And we could see that the cat was obviously a diabetic at 500 milligram per DL. We could say that's real because I'm not going to see stress hyperglycemia cause that. The cat had azotemia at 72. Normal and conventional U.S. units would be around 20 to 30 for the cat. We found that the cat was markedly hypokalemic. That's, mind you, 1 week prior to presentation. The chloride at that time was normal at 111. PCV normal. At the referring veterinarian, the pH was 7.1. Normal being 7.35 to 7.45. So we had ourselves some acidemia, while the total CO2 was decreased, which made us think that bicarbonate was low. Thus, we're thinking of a metabolic acidosis. And then the anion gap was 24, which goes along with a ketoacidosis that diabetes mellitus can cause. Now, mind the PCO2 here. That's the partial pressure of carbon dioxide, which is normally 25 to 35. So something is causing this cat to retain carbon dioxide gas in his venous blood. And we all know that when animals become hypercarbic, it's always due to impaired ventilation. So already we have to start thinking about why can't this cat ventilate appropriately, and does this have anything to do with anything else on this serum chemistry panel? And you could see the other green arrow obviously pointing to the low potassium, and the answer to that is yes, severe hypokalemia can cause what we call hypokalemic myopathy, that could even go on to involve the muscles of respiration, including the intercostal muscles and the diaphragm. So this could be pretty serious for this cat. And we're going to have to bear that in mind when we draw up our treatment plan. The azotemia bothers me. I hope that is pre-renal. And going back to this cat's urinary concentration, I do believe that he was able to concentrate somewhere in the 1020s, so he was not isostenuria. Okay, so when the cat got to the University of Florida, we find that he was still hyperglycemic at 525, still azotemic at 58, the creatinine 2.1. So we still had ourselves some mild to moderate azotemia. but now his potassium was 1.5. Now that is real scary because at that point, neuromuscular function can fail because we need adequate amounts of potassium for ATP to function normally at the muscle level, and that's going to make us really focus in on this cat's respiration. Remember that the chloride was 111 milliequivalents per liter, and now it's 86. Now the significance of that, you have to ask yourself, what could lower the chloride? And what will lower the chloride most of the time is an animal that vomits and loses hydrochloric acid from his stomach, thereby going into an acid deficit that puts him into a base excess. So that 86 chloride is significant. Even though the owners didn't profess seeing vomiting, the cat could have been doing it when they weren't looking or they never noticed it. We see that the phosphorus 2.7 is getting on the low side, but it'll hang in there, and the ALT wasn't too elevated. The cat's pH was 7.2, so again that's a little bit below normal, and this is most likely due to his metabolic acidosis, but that's going to be compounded at this point. Again, that PCO2 is elevated. Now, when we see hypercarbia, that's respiratory acidosis. So what this cat is sitting on here is a metabolic, he should have a metabolic acidosis. He was a bit azotemic. You see he had some ketones in his urine, but then when we look at his bicarb was actually just a little bit above normal. So why was the cat acidotic? It wasn't so much due to base deficit, because the cat had more base than it could handle. Remember, it lost all that hydrochloric acid from his stomach. So why is he acidotic? Here it is right there. That PCO2 is elevated, and that's causing him a respiratory acidosis. We see he was able to concentrate his urine to 1023. He was glycosuric, so maybe he did have some renal tubular dysfunction, but 1023 is certainly better than isostenuria. He had a little bit of protein. The bacteria was reported as mild, which could have been an apparition, but we would probably start treating for a urinary tract infection. So what brings us to mind here is the big question: what is the association between the potassium and the elevated PCO2? And as we already answered, we have ourselves a hypokalemia that is interfering with muscle function, and the muscles of respiration are dysfunctional, allowing for CO2 to be retained. And with such an elevation in the partial pressure of carbon dioxide, we have ourselves a respiratory acidosis. Mind you that the PCO2 is different from the total CO2, where the total CO2 that comes out in most of our chemistries is reflective of bicarbonate. So we use the total CO2 and bicarbonate as essentially the same the same factor, with the PCO2 representing carbon dioxide gas. Because of the severe hypokalemia, we were worried about his EKG or his cardiac function, and you could see here on his EKG that we definitely had abnormalities where his P wave was taller than the R wave, and we could barely see a T wave that was fairly flat. And this is because with hypokalemia, we can have a state of hyperpolarization at the myoneurojunction, and the heart is going to be affected by this as well. So the heart's going to be in a hyperpolarized state, and it won't be able to generate its action potential to give you an adequate cardiac output. So we're really at the extreme situation with hypokalemia, and we're going to have to really think about some intensive therapy on this little kitty. So, which brings us to how should we manage this particular patient? And I'm going to ask you to think about looking at his problems of dehydration. Therefore, we need some isotonic fluids. And because he's low in chloride, the optimal fluid would be what? It would be sodium chloride, 0.9%, because it's isotonic. And then we know that we have to add potassium to that. And when they're already that low, you have to go beyond the usual supplement dose of 20 milliequivalents per liter. And in this case, this cat's going to be as high as 80 milliequivalents per liter as we begin potassium treatment. The next question is tricky. Should we begin insulin? And my answer to that is no. Do not begin insulin, because insulin will push the potassium that's in the extracellular space intracellularly, further lowering the extracellular potassium, and that might be devastating to this cat. So I'm going to hold off on this insulin in the anticipation that I could just give IV fluids, and by solving the dehydration, I could sometimes reduce the blood glucose by up to 50%. So I'm going to hold off insulin on this cat for as long as 12 hours, maybe 24 hours, until I get a chance to give the sodium chloride that's supplemented with the potassium chloride, and I'm going to infuse that and at such a rate so that the potassium infusion does not exceed 1.5 milliequivalent per kilogram per hour. Now, this is a bit higher than the standard dose of potassium, where they say it shouldn't exceed more than 0.5 milliequivalent per kilogram per hour. But in extreme situations, as we have here, with serum potassium down as 1.7, 1.8, I'm going to take it as far as I could and perhaps keep the cat on a Holter monitor to make sure that I don't make it hyperkalemic with my high supplementation. So we're going to proceed here and see how we go along. We started off by adding 50 milliequivalents of potassium chloride to the drip, just to see where that would take us after 6 to 8 hours. And we will see in a minute, it didn't really raise the potassium that much, and we had to intervene at around midnight and raise that potassium dose. And but I want you to just kind of witness right here that the initial EKG that looked real bad here started to improve, where we did get the potassium by the next morning up to 3.5. So things did have a happy outcome with that. So basically what happened at the midnight check, after we had supplemented with 50 milliequivalents per liter, we basically upped that to 80 milliequivalents per liter and went on to deliver that slowly to where you could see on the next day we were able to get the cat's serum potassium up to 3.5. So the take-home messages on baby Hannel stresses the importance of the appropriate fluid. And whenever you have an animal that's dehydrated with a low chloride, the optimal fluid of choice is going to be an isotonic fluid that's high in chloride, and that would be 0.9 saline, because 0.9 saline has 154 milliequivalents of chloride per liter, as opposed to lactated ringers that only has approximately around 107 milliequivalents of chloride per liter. I also want to emphasize the need for potassium. Even if dogs and cats come into your practice with normal potassiums initially when they're in diabetic ketoacidosis, by the time we give fluids, by the time we give insulin, you can expect to see that they will have hypokalemia by day 2. So that's why I always start them off with the potassium. I usually like to go with just the saline for the first hour or two, get them a bit hydrated, and then add the potassium chloride to the rehydrated cat. But when the potassium is real low in a life-threatening mode, like it was with this cat at 1.8 or 1.7, then I would go ahead and start my fluid replacement with potassium in the drip, and then make a few calculations so that the drip does not deliver more potassium than 1.5 milliequivalent per kilogram per hour. The third point I introduce is this new term, ketoalkalosis, and this is a term whereby you have a combined ketoacidosis and a metabolic alkalosis. And the ketoacidosis was obvious from the ketones from the diabetic state, and the alkalosis was due to the fact that the cat was probably vomiting and had become hypochloremic, thus giving you a mixed acid-base disorder. The fourth point I want to stress is the timing of the insulin administration, and take heed to the fact that giving the isotonic fluids by itself might lower the blood glucose by as much as 50% over 12 hours. So you don't have to go pushing insulin to them right from the beginning, especially if they're initially hypokalemic, because that insulin will go to work faster, making the animal more hypokalemic before it has a chance to get potassium replenished by the IV fluids. So to sum it all up with baby Hennel, the importance of adjusting the treatment in this particular situation is that you want to adjust the treatment according to the specific needs of the patient. And this I apply right across the board in all my patients when I am dealing with a disease, with any illness. The patient is always in the center of my thoughts, and I always ask myself, where am I with this patient? And the next question is, where am I going with this patient? So take heed of that, and hope these take-home messages help you.